class, part 1, I explained about the causes of CA maxilla, then the clinical features, the spread of carcinoma maxilla, then staging, then the method of investigation and the principles of treatment. So in this class I will explain about the different types of maxillectomy, or as written here, the surgery for maxillary tumors. They are very important, and for this you need a very good understanding of the surgical anatomy of maxilla, which was already taken in a previous class. Okay, so from this maxilla we want to remove the diseased parts. We want to isolate the diseased parts. So the type of surgery depends upon the bulk of tumor and the amount of bone to be removed. So the bulk of tumor and the amount of bone to be removed. Depending on that, we have to plan different types of maxillectomies. The surgery for maxillary tumors can be broadly divided into a partial maxillectomy, total maxillectomy and extended maxillectomy. So what is this partial maxillectomy? We are removing of the maxilla or the apogee. We are partially removing it. It becomes partial maxillectomy. So if the lateral wall of nose, that is the medial wall of maxilla, along with the ethmoid sinus is removed, it becomes medial maxillectomy. Okay, so the medial wall of maxilla or the lateral wall of nose along with the ethmoids removal is medial maxillectomy. Then palatal resection with the adjacent, that is the removal of the hard palate along with the adjacent alveolus is removed, it becomes palatal resection. It was earlier called as a fenestration operation. And actually it was termed for making a hole in the palate for putting radium implants into the maxillary antrum for tumors. Nowadays, most of the cases, this fenestration, after putting the fenestra, it is closed with the palatal flaps. Okay, so that is partial maxillectomy. And in total maxillectomy, we remove the maxilla as a box of bone containing the tumor. And if this maxillary malignancy extends beyond maxilla, it can be into the orbit or it can be into the base of skull. So if it is, that is called an extended maxillectomy, and if it is involving the skull base, we call it as a craniofacial resection. Okay, so these are the three types of maxillectomies: partial, total and extended maxillectomy. Now we can see what are the different approaches, soft tissue approaches for each of these maxillectomies. Soft tissue approaches to the maxilla are mainly of three types. One is lateral rhinotomy incision, which is known by the name of Mohs lateral rhinotomy incision, which is mainly used for medial maxillectomy procedures, and other one is Weber-Ferguson incision, and third is a midfacial declavering incision. So first I will tell about the Mohs lateral rhinotomy incision. That starts from the midpoint of medial canthus of eye and the dorsum of the nose. It starts from here and then it comes downward through the lateral nasal groove or the lateral facial groove. It comes downwards and it encircles the ala of the nose and it goes into the nostril of the nose. If we want an extended approaches or extension or more exposure, this can be extended into the philtrum or it can be extended along the orbit also. Okay, so the classical Mohs lateral rhinotomy incision is this one, extending starting from midway between the dorsum of nose and the medial canthus of eye, coming down through the lateral facial groove or the lateral nasal groove, coming and encircling the ala of nose and going into the nostril. And for all these procedures, first you have to do a lateral tarsography. Okay, patient supine with a reverse Trendelenburg with a 15-degree neck flexion, lateral tarsography, then incision is put, then incision is extended up to the periosteum. Then now you can see that very clearly here. So the incision is extended up to the periosteum, and when we reach the periosteum has to be elevated. Okay. Once we reach the periosteum, it has to be elevated. So the upper limit of in this, the upper limit comes here. That is the frontoethmoid suture line. On elevating the periosteum, you will reach the frontoethmoid suture line, and also here you can see the lacrimal fossa. So attached to the lacrimal fossa on the two sides, anterior and posterior lip, comes a medial canthal ligament or medial canthal tendon, and it has to be elevated and detached from the lacrimal fossa, and this lacrimal sac has to be taken out and it has to be marsupialized. Elevate the periosteum laterally and into the from the floor and from the medial wall of the orbit. So the superior limit will come as frontoethmoid suture line. It comes here. Okay, frontoethmoid suture line. Because above the frontoethmoid suture line, if you go superior to the frontoethmoid suture line, there is chance of disturbing or reaching into the intracranial content, injury to the intracranial content, and CSF leak can occur. So always the superior limit is the frontoethmoid suture line. And in the orbit, here comes the anterior ethmoid artery and then comes the posterior ethmoid artery. So the anterior ethmoid artery has to be cauterized with bipolar cautery, and there is no need to go up to the posterior ethmoid artery. So the posterior limit inside the medial wall of orbit is the posterior ethmoid artery. Okay, so incision deepened, periosteum excised, and then periosteum elevated. The superior limit is the frontoethmoid suture line. Posterior limit in the orbit is the posterior ethmoid artery. Okay, and then detach the soft tissues from the piriform aperture. Elevate the periosteum here on the anterior wall of maxilla. So in the anterior wall of maxilla, one important landmark is the, what is here? What comes here? Inferior orbital foramen. Okay, so up to the inferior orbital foramen, and you can make an androstomy here, and through the androstomy inspect the inside of the maxillary antrum, and once more confirm the extension of the tumors. Okay, and after that comes the osteotomies. So the first osteotomy comes here, that is in an anterior to posterior plane into the inferior meatus. You can use either an osteotope or a heavy scissors can be used. If you need, you can also use drill for that. Micro drills can also be used. So in an anterior posterior direction, horizontally through the antrum, make the first osteotomy. Okay, so it goes upwards, and the superior limit I already told, it is a frontoethmoid suture line, and from there it should stop. The posterior limit is the posterior ethmoid artery, and then it should encircle the lacrimal fossa and should reach this vertical cut. Okay, and then here the osteotomy comes from along the lateral nasal bone, that is the naso-maxillary suture line. Right? So now you can rock the bony piece from the soft tissue attachments and can take it out. Okay, clear? So the removed part will be, this much of part will be included. That is the inferior turbinate, middle turbinate along with the superior turbinate, and the medial part of medial wall and the floor of orbit, and also the maxillary antrum anterior to the posterior wall of maxilla. So this much of part will be removed in a medial maxillectomy, and you should remember that the superior limit is always the frontoethmoid suture line, and the limit in the medial wall of orbit comes the point just anterior to the posterior ethmoid artery, and it should include the lacrimal fossa, and the lacrimal sac should be dissected out and should be marsupialized and sutured to the posterior edge. And in the anterior face of maxilla, it is a vertical cut comes just medial to the infraorbital foramen. This infraorbital vascular bundle and the nervous bundle should not be disturbed, and it should go through the inferior meatus from anterior to posterior direction, and the posterior limit is of the antrum is just anterior to the posterior antral wall. Okay, so from that it is taken out after taking care of the neurovascular bundle and the soft tissue attachment. So that is about medial maxillectomy. Then what about this midfacial deglowing approach? That is the pyrrhoaperture, that is the nose along with this upper lip on both sides. If we deglow or elevate it, this much of area should be widely exposed. Okay, for that we have to put incision in the nose, and also bilateral sublabial incisions has to be put. For that, in the nose, we want to put 3 incisions in the nose, 4 incisions in the nose. The one we put is as we put hemi-transfixion incisions for septoplasty, isn't it? So here, that is at the caudal end of septum, we put the hemi-transfixion incision. If it is carried out on both sides, it becomes a full transfixion incision or a complete transfixion incision, and that is combined with an intercartilaginous incision. That is I talked about when I explained the incision approaches in a rhinoplasty. Intercartilaginous incision, that is between the lower lateral cartilage and the upper lateral cartilage. It comes almost here. Okay, and through that you can reach into the dorsum of the nose. So here we are putting intercartilaginous incision on both sides. And also here we are putting the pyriform incisions in this part here, the soft tissue, this part. Okay, so that is pyriform incision, and now it is attached to the lower part. So floor incisions has to be put, nasal floor incisions. Okay, and along with that sublabial incisions. Starting from one first molar, it should go bilaterally to the opposite first molar. Here comes the canine eminence or canine ridge. From there, here will be the first molar. So from one first molar sublabially, it should go to the opposite first molar. So bilateral sublabial incision. And these incisions are deepened, and it is elevated as a flap upwards. Okay, so that the entire soft tissue part and the lower lateral cartilage will be elevated. So you will get a beautiful exposure like this. Okay, so with the sublabial incision we can elevate that part, and with the hemi-transfixion along with intercartilaginous and pyriform and floor incision, all these are made upwards or elevated as a single block, so that there is a beautiful visualization of this entire area. And the advantage is that there is no facial scar, and the midline or a very large tumors can be exposed and removed very beautifully. Okay, so that is about midfacial degloving approach. Total maxillectomy using Weber-Ferguson incision. So I am not explaining every details, only the important salient points or the important points will be discussed here. So in the pre-operative preparation, the most important consultations to be made are, one is a prosthodontic consultation or dental consultation, because the need of fitting of very high quality dental processes. Immediately after surgery, temporary process should be placed, so that has to be kept available pre-operatively itself. Then the consultation with an ophthalmologist is needed, and also psychiatric consultation is needed because of the morbidity and the facial scar, and if needed there will be prolonged hospital stay will be needed. And the informed consent is also very much important. Pre-op preparation including informed consent, then position that was already explained, anesthesia. You need both topical anesthesia and general anesthesia. So topical anesthesia with Moffat solution and also general hypotensive anesthesia is highly preferred, and many surgeons will prefer an nasotracheal intubation, that is 2 on the opposite nostril, rather than an orotracheal intubation, and that is better preferred. And if needed, you can also put a tracheostomy, so that this surgical field will be entirely on the hands of the surgeon. Okay, so that is regarding anesthesia. Then incision. So I'll explain the classical Weber-Ferguson incision, but it is rarely used now, and there are so many modifications made to Weber-Ferguson to make it more cosmetically appealing. But our intention is to remove the maxilla as a block from the facial skeleton. There will be a transverse limb which should go close to the lid margin in order to avoid lid edema. Okay, and classically this should go down as in a acute angle, but it is better to, because there is chance of tissue loss in this area after radiotherapy, so it can be made more curved into the nasal bone, so that there will be a support in the post-operative phase. After that, it is curved around the nasal area, coming to the midline, then coming down. The classical, it is a midline lip splitting incision, but it is always better to make it somewhat curving to the philtrum and going to the midline and lip splitting. Okay, and after that it will come in the midline of the hard palate, ends here, and then comes the soft palate. So at the midline in the hard palate, at the junction of hard and soft palate, it curves laterally, and it encircles the greater tuberosity, and along the alveolus it goes anteriorly. Okay, so this is Weber-Ferguson incision. It has got a transverse limb, then coming down in the midline lip splitting, then in the palatal it is in the midline of the hard palate, and at the junction of hard and soft palate it curves laterally, encircles the anterior tuberosity and going anteriorly along the alveolus, and this incision is deepened up to the periosteum. All the soft tissue attachment to the bone are removed, and then we can do osteotomies. You can see the frontal process of the maxilla one side, then body of zygoma on the other side, and there will be parietal resection on this side, and also posteriorly it has to be freed from the pterygoid plates. Okay, so the osteotomies are similar to this. Okay, here comes the frontal process of maxilla. So frontomaxillary suture line is the upper limit. Here you can have to make the one osteotomy, and second osteotomy comes at the body of zygoma here, and the third osteotomy is at the midline at the palate, that can be done through the floor of nose. Okay, you can use a giggly saw, or you can use, ideally we use giggly saws. But it is the preference of the surgeon, either wires or giggly saw, rugers or chisels or burr, anything can be used. Then posteriorly there is a pterygoid plate, so this has to be freed from the pterygoid plate. For that you can use curved scissors can be used. Okay, so the main osteotomies are one at the frontal process of the maxilla, just below the frontoethmoid suture line, then through the body of zygoma, then the palatal cut, and it has to be freed from the pterygoid plate. At the posterior part there comes the terminal branches of the internal maxillary artery. So on removing the maxilla there will be torrential bleeding that has to be, initially it can be controlled with packing, or later cautery or even clipping can be done to control bleeding from the maxillary artery. First Weber-Ferguson incision, then comes osteotomies. Now you know the osteotomies now. With this it is very clear. I already told there is one at the frontal process of maxilla. Here comes the orbit now. Frontal process of maxilla, body of zygoma, then through the nose, transection of the palate, and then it is freed from the pterygoid plates using a curved scissors. And after osteotomy, there is completion of the resection. Completion of the resection, that is, all the areas should be inspected carefully, and if there is tumor extension, that has to, soft tissue extension or any remaining tumors, that has to be removed in total. The ethmoid sinus should be excentrated totally, and the frontal, here comes the frontal, and the sphenoid sinus should be opened widely. And if there is involvement of the orbital periosteum, orbital excenteration has to be done. After orbital excenteration, usually the eyelids are preserved, but the lid margin and the tarsal plates are excised so as to make a smooth skin-like cavity to which an online prosthesis can be fitted. Okay, and next is rehabilitation. That is, by carefully doing the work, a very good healed cavity can be made. So ideally the healing is very fast, but even then we keep a split skin graft in the cavity, and immediately after surgery this temporary processes has to be inserted. Otherwise there will be immediate post-op, there will be problems with swallowing, feeding, and also cosmetic problems will be there. In order to avoid that, we keep a temporary processes at the time of closing the cavity itself, and this has to be the patient has to be followed up after 14 days, and the temporary processes has to be replaced periodically as per the healing of the cavity. This has to be continued for so many times. Okay, it has to be followed up until a well-healed cavity is obtained. So that is all about total maxillectomy. I told about the pre-op preparation, position, anesthesia, incision. Osteotomies, actually the osteotomy is difficult for many of the students. By looking at this, it will be easy. So here comes the frontal process of maxilla, the laterally body of zygoma, then palate and freed, mobilized posteriorly from the pterygoid plates. Okay. Then the completion of resection, looking into the orbital part to decide on whether to do an orbital excenteration or not, and also rehabilitation. So we talked about medial maxillectomy using a lateral rhinotomy incision, then the approach of midfacial degloving, and also the classical Weber-Ferguson incision and a total maxillectomy. Thank you.